If you want to know how to deal with NDIS support coordinators that can't advocate for you, especially when you or your loved one have a ventilator, tracheostomy, or need home TPN, or have BiPAP, CPAP ventilation, or have a tracheostomy without ventilation, stay tuned. I've got news for you. So obviously we are operating in the NDIS space, but also TAC, DBA, iCare in New South Wales, NIISQ in Queensland. But obviously we're dealing with a lot of NDIS participants. And by the way, my name is Patrick Hutzel from intensivecareHome.com. And so we're dealing with a lot of NDIS participants that have conditions such as cerebral palsy, Rett syndrome, motor neuron disease, but also spinal injuries, and all of them are heavily NDIS funded for 24-hour critical care nurses because they have critical care nursing needs. Otherwise, those clients would be in intensive care, or if they didn't have the critical care nurse, they would actually be passing away. So this week, I had a phone call from an NDIS support coordinator, and we've been asked to do a nursing assessment about 6 months ago for a very vulnerable client with cerebral palsy. And the client is known to have an unstable airway, recurring ICU admissions for aspiration pneumonia, and the client has a long-standing medical history of cerebral palsy, moya disease, multiple strokes, quadriplegic cerebral palsy, epilepsy, dysphagia, recurrent aspiration and aspiration pneumonia with intensive care admissions, scarring of the right lung, kyphoscoliosis, muscle contractures, percutaneous endoscopic gastrostomy, also known as a PEG tube, and is known for being high risk for pressure injuries. And the client initially came to us asking for an NDIS nursing assessment, knowing full well that support workers and the help of her family will not keep this client out of hospital predictably, which is why they were coming to us for an NDIS nursing assessment. So the nursing assessment was done, by the way, by an independent clinical nurse consultant with a critical care nursing and legal nurse consultant background. And the nursing assessment evidently was recommended for 24-hour nursing care with critical care nurses for the reasons that I just mentioned. So what normally happens is those reports go to the NDIS, and the NDIS often rejects the request for 24-hour nursing care, but with the right level of advocacy. We always get the funding for our clients because that's part of what we do, and otherwise we wouldn't be in business, right? We wouldn't be employing over 100 critical care nurses in the community if the funding wasn't there through the NDIS or other funding bodies. So to come back to the phone call that I had from the NDIS support coordinator this week, she calls me up and she said, look, thank you for the nursing assessment, but I'm wondering whether the writer, the critical care nurse, can change the recommendations from 24-hour critical care nurses a day to 1 hour of a registered nurse a day, because the NDIS won't fund the 24-hour nursing care. I said to her, with all respect, this is a report from a professional that is APRA registered. Your job as NDIS support coordinator is to advocate for your client depending on the reports that you get from a professional. Now, the problem with many NDIS support coordinators is that there's no regulation who can become an NDIS support coordinator. Anyone can become an NDIS support coordinator. There's no selection criteria, really. With all respect, they might have worked in a supermarket the week before stocking shelves, with all respect, and now then putting the label on them, NDIS support coordinator. And that is really dangerous, especially when we're dealing with super vulnerable clients on ventilation, tracheostomy, BiPAP, CPAP ventilation, and so forth, right? Basically, patients that otherwise would be in intensive care, which for this lady has been the case, or are at risk of medical emergencies and therefore are at risk of dying. So I explained to her that her job is to advocate for the client and that the NDIS is not the regulatory body, but APRA is. So what do I mean by that? All registered nurses are APRA registered, right? And APRA sets the guidelines. So that means registered nurses, a registered nurse's skill is to make a professional assessment what nursing care a client or a patient needs. That is part of their skill. And if a registered nurse would make up things that are not accurate, they could lose their registration. So why would a registered nurse or a doctor or any health practitioner for that matter make up things that are not true, because their registration could be at stake? The problem with the NDIS and NDIS support coordinators is that the NDIS wants to undermine registered nurses and their APRA registration. They also want to undermine APRA by, not funding what is clinically necessary. So also what we have done, there's two things that we've done in the meantime. Number one, we've always successfully advocated for our clients to get the funding because, as health professionals, we have the skills and the knowledge and the know-how to do so. That's one thing we've done. And we also know how to engage NDIS support coordinators if they are potentially lacking the insights or the skills to advocate for the right level of funding, right? The other thing that I said to the NDIS support coordinator, I said, well, you need to either challenge the plan review or you need to take this case to the tribunal, right, to the NDIS tribunal. And many cases have been turned around there, where the NDIS tribunal, gives the client what they need according to the professional assessments, whether it's a nursing assessment, whether it's a doctor's letter, whether it's an OT report, whether it's a physio assessment, right? So to continue there, what we've also done in the meantime is we have sought some legal advice around this. So what that means is we have said what would happen if the NDIS rejects funding, but the client is at risk of dying or going to hospital. The lawyer says, and we've also studied more of NDIS legislation now, that if a client is at risk, that it is actually our obligation to send our nurses to keep the client safe. And it's then the NDIS obligation, as per NDIS legislation, to pay for it, right? And we've put that to the test in the meantime, and it is absolutely true, right? On one of my next videos, I actually will read out the letter of advice from our lawyer to shed more light. So stay tuned. In the next few days, one of my next videos here will be about the legal advice that we sought, received, and also put in practice already with much success. So for this particular client, and I've advised the NDIS support provider, we'll just put nursing in place, and doesn't have to be us, could be another provider if there is one, and make sure that NDIS participants are safe, and then deal with the NDIS as per legislation, right? Most NDIS support coordinators have no idea how the NDIS works or how the NDIS legislation works. The NDIS is actually there to protect people, not to go after them. I've learned that the hard way too. Bottom line is this particular client is now at risk of dying because an NDIS support coordinator cannot properly advocate, doesn't understand legislation, and really has no interest to provide best and evidence-based care for a very, very vulnerable client on the NDIS. So with intensive care at home, we're currently sending our critical care nurses into the home 24 hours a day. Therefore, we are providing a genuine alternative to a long-term stay in intensive care for ventilation, tracheostomy, home BiPAP, home CPAP, ventilation without tracheostomy, tracheostomy without ventilation, home TPN, home IV potassium infusions, home IV magnesium infusions, IV fluids, and IV antibiotics. We're also providing ventilation weaning at home. We're also providing central line management, peak line management, Hickman's line management, as well as port management at home. We're also providing nasogastric tube and PEG tube management at home, as well as palliative care services at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of going to the emergency department. Therefore, we're also in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs around $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day. We're freeing up the most sought after bed in the hospital, which is the ICU bed. But most importantly, we're improving the quality of life of patients and their families, which is a win-win situation for all stakeholders. With intensive care at home, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are an NDIS approved service provider all around Australia, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as the Department of Veteran Affairs all around Australia. Our clients and we as a provider have also received funding through public hospitals, private health funds, as well as departments of health. We are the only service provider in Australia that has achieved third-party accreditation for intensive care at home nursing in 2025. We have been achieving this high level of accreditation since 2012. No other provider has achieved this high level of accreditation in the community and has created more intellectual property for intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. And if you are at home already and you're watching this and you realize you don't have the right level of support, or if you're stuck in an ICU long term, or if your family member is stuck in an ICU long term, I'll give you a tangible and real world example today. One of our first clients about 10 years ago, when we first got started, was a client who was at home, initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, it's dangerous and negligent having support workers looking after a client at home on a ventilator with a tracheostomy. That's like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies or dying if they don't have a team of critical care nurses looking after them 24/7. This is actually evidence-based, and it's documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care in a hospital, you wouldn't have support workers look after a critical care patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? So eventually this client found out about us. We were proving our concept with this client very fast. When we worked with the client, we sent him intensive care nurses 24 hours a day. He never ever went back into ICU ever again. And we were proving our concept there very fast. We can do the same for you if you're not safe at home, which includes the advocacy for funding that goes along with it. We have always successfully advocated for our clients. Otherwise, we would not be in business. The same is applicable for those stuck in ICU, similar to our case, to what you are looking for. Reach out to us. We'll make it happen for you as well. We can take you through the right steps. And that is also why we are providing level 2 and level 3 NDIS support coordination. We have a team of NDIS support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Riches, one of our NDIS support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog below the video. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCodder. And if you're an NDIS support coordinator or a case manager from another organization watching this, and you're looking for nursing care for your participants, please reach out to us as well. If you're looking for funding for nursing care for your participants and you don't know how to go about it and what evidence to provide, I encourage you to reach out to us as well. We will help you with the right level of funding and with the right level of advocacy. We're also providing NDIS specialist nursing assessments done by critical care nurses with a legal nurse consulting background. And if you are a critical care nurse and you're looking for a career change, you want to join a very progressive, dynamic, and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. If you're looking for a career change, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, and in Warragul in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I have a disclaimer. Because we are offering a tailor-made solution for our clients, which includes regular staff, our clients also do want the same staff coming over and over again because they are so vulnerable and so special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We're looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availability for shifts. You're really keen on building relationships with us and with our clients. And if you are an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in ICU and in your ED for long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds. And in most cases, you won't even pay for it. even if you do pay for it, it is much more cost effective than what you're paying in ICU and ED for, and you get the same level of care. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED and respiratory wards, home TPN, of course, please reach out to us as well. We can help you eliminate your bed blocks very fast. And if you're in the US or in the UK and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.